During this presentation, we're going to look at essential occlusion in restorative and aesthetic dentistry. So, as you can appreciate, this is a vast topic. So, let's pick out one aspect of this topic and move on to that. So, what are we going to look at during this presentation? Well, let's look at the features of the ideal occlusion. So, if we could design an occlusion from scratch, what would be the features of that ideal occlusion that we would choose to have? And I think that's always very useful to look at, because if you know what an ideal occlusion is, you can then see how far away from that, the mouth that you're examining, how far away from that ideal is the patient's occlusion that you're examining. So let's look at that. And then we'll look at some of the occlusal disorders that may prejudice the outcome of restorative or aesthetic dentistry. So these are very fundamental points. Now, during this short presentation, I'm not going to go through all of the occlusal disorders that could prejudice your dentistry, but I will focus in certainly on some of the more interesting ones and some of the more fundamental ones for you. So what's the importance of occlusal diagnosis? Well, back in 2015, I wrote an article for Dentistry called Occlusal Confusion. And really that article looked at aspects of the ideal occlusion, occlusal examination, and then actually looked at a clinical case which had occlusal issues as well. And do bear in mind that occlusal kind of aspects of restorative and aesthetic dentistry, or even TMD dentistry, can be quite controversial. But I think it's very important to reiterate that what I said in that article was most patients function perfectly well with a less than ideal occlusion. So when you look at your patients, most of them will have a less than ideal occlusion. However, there is a fundamental difference between looking at that occlusion, deciding it's not ideal, and accepting and monitoring it. And there is a difference between that and actually just failing to diagnose that there was ever an issue in the first place. So not all occlusal disorders require treatment, but some certainly do. So let's go on to look at the features of the ideal occlusion. So what is the ideal occlusion? Well, it actually almost starts before the teeth come together. What you want is a stable and comfortable, particularly closing pathway for the patient. So who might lose that? You might not have a stable closing pathway if you have some sort of neuromuscular disorder, particularly these days with an elderly population, with people like Parkinson's or MS. Certainly if you've tried to make dentures for these patients, trying to record centric relation on them is really difficult. And just a simple factor such as a heavily over-erupted back tooth that's tilted, that may have become an occlusal interference, and to stop gnashing into that tooth, the patient may have a different bite or a different closing pathway to try and avoid that, and that may not be a stable or consistent closing pathway. Now, when the teeth actually come together, what you actually want is a simultaneous, stable cusp-fossa contact. When the teeth bite into the intercuspal, or the maximum intercuspal position, which is essentially the position of best fit. And that can quite easily be upset by over-erupted or tilted teeth. It could be upset by having multiple missing teeth, and it could be upset by something like erosion, where you actually don't have a good cusp-fossa relationship. So what do we want for that? We want adequate cuspal form, so that when the teeth come together, we have an intercuspal position. And we don't want any anterior-posterior or any lateral slides caused by posterior interferences. Now, it's not really the scope of this lecture to look at how we would really look at these anterior-posterior interferences. That might involve bimanual manipulation. It may involve the use of short or long-term deprogrammers, and so that's a whole topic within itself. Something we'll come back to during this presentation is canine guidance. And canine guidance means that on lateral movements of the jaw, particularly during chewing, that the canines are essentially separating ramps. And they cause the back teeth to separate and the front teeth to separate on both sides of the mandible when lateral movements are made. And let's come back to that and look at that in more detail, because that is a very pivotal point of an ideal occlusion. What we also want is smooth anterior guidance on the palatal surfaces of the anterior teeth. So when you move your mandible forwards, the back teeth separate, and that should be smooth guidance with no posterior interferences. Something that we often overlook, but I'll come back to this later in the presentation, is a sufficient envelope of function, and that really requires the occlusion to have an adequate overjet and an adequate overbite, or not an increased overbite, to accommodate forward movement during chewing, and we'll look at that in more detail. And so what do we want from an ideal occlusion? Well, we're actually just creating a chewing machine, and we really want a chewing machine that is free of interferences, so that's your fundamental thing that you're looking for. And what occlusal or TMD disorders may prejudice our restorative or aesthetic dentistry? Well, lack of canine guidance can, because you may get interferences or increased tooth wear. Deeper overbites are a problem because you can end up with increased frictional wear on your front teeth particularly. The restricted envelope of function that I'll consider in more detail can particularly lead to anterior tooth surface loss, and the posterior interference can lead to abnormal posturing of the mandible. That may cause interferences and problems with particular teeth. It may start to cause effects on the whole dentition, or even start causing temporomandibular dysfunctions. And if you put restorative dentistry into any of those situations, the likely prognosis for that restorative dentistry is going to be poorer at the end of the day. What else would be an occlusal disorder that could upset our restorative dentistry? Night parafunction, because patients who parafunction at night could be grinding for perhaps 40 minutes an evening, and they could be putting 5-6 times more than the normal amount of pressure or load through the teeth. Day stress clenchers, interestingly enough, can produce as much damage just through the sheer stress clenching during the day. And habits such as pen chewing, nail biting, builders who carry nails in their mouth, electricians who sort of strip the plastic off wires, all of that can cause problems as well. And finally, what can upset the whole system as well is erosion. So acid softening the teeth so that the parafunction wears the teeth more quickly, or the deep overbite becomes more of a wear problem because the teeth are softer. So a lot of things that can prejudice our restorative dentistry. So let's look at a slide of canine guidance. Very straightforward. The canines, look here, are separating ramps. The patient's making a lateral movement, and there's a vast amount of space between the premolars and the molars. So there's no chance there of a posterior interference developing at any time in the future, unless perhaps one of those teeth is lost. And you could see that you would have to get a lot of canine wear for a posterior tooth to become a lateral interference there. But look at the upper lateral and central incisor. Look at the lateral particularly. And hopefully it's really obvious that there is only a whisker of space between those teeth. And you can imagine that if you got 1 or 2 millimeters of wear on those canines, then before you know it, those lateral incisors would be guiding the occlusion, and they would be particularly prone, because they are so thin, to wear. So that's the importance of canine guidance, very, very important, particularly to anterior restorations. And let me show you how important it is. This is a case that had pre-orthodontic treatment to correct the occlusion, but it's a fairly blatant case as well. And look at the upper right canine and look at it being in crossbite. Look at the upper left canine and look at how the lower canine doesn't really interdigitate with it because of crowding. So on both sides of the mouth we have a lack of canine guidance. And what did this cause the patient to do? Well, look at the occlusal view in the middle and look at the periapical radiographs. The patient, who had quite small fillings in these teeth, actually managed to break the teeth structurally to a degree where, look at these large composite pinned emergency restorations that were placed by the dentist. And this patient doesn't even parafunction. But look at the consequences of this lack of canine guidance, really serious. And if you look more closely, look, there are telltale signs of an occlusal disorder. Look at the wear facets on those lower incisors. One look at those during a clinical examination would ring alarm bells of increased frictional load. And so this is quite typical of a lot of the more advanced cases I treat, where we undertook pre-orthodontics to improve the occlusion. And in this case it was undertaken with just short-term, more cosmetically focused ortho in terms of 6-month smiles. But if we look at the bottom, we can see that already the occlusion is improving. We're improving the crossbite on the right, we're improving the overbite, and we are re-establishing the canine guidance. And here we are very much at the end of the orthodontic treatment, and we can see that the canine guidance has very much been re-established with a protective occlusion for our anterior restorations. We could then undertake our cosmetic work, and using something we're going to come back to later in the lecture, which is the cosmetic functional diagnostic wax-up. And so we use the wax-up to do a biological prep-through guide, and you can see that on the bottom right of the screen are our minimal shell Emax preparations. So minimal tooth preparation on these teeth that are already very compromised with the large composite restorations. This wax-up then enabled us to provide the provisional restorations and then controlled our final restorations, which are press-only, highly aesthetic Emax minimal crowns. And also with the re-establishment of the canine guidance, crowns that should have a long durability for the patient. And certainly since these crowns were fitted about 5 years ago, the patient has had no problems with these at all. And so, you know, this is echoing certain aspects of modern dentistry that I teach a lot, and these are what I would call shell Emax or 360 veneer preparations. So these are extremely minimal preparations, and then using Emax as the final restorative solution, and press-only Emax. So this is a strong monolithic, but still highly aesthetic. And bottom right, you can see that we've actually made allowances for our orthodontic retention long term, with a small channel cut for our fixed retention in this case. And if any of you are more interested in this case, I did write this up in Dentistry magazine back in 2014, and really looking at how we can achieve long-term stability in aesthetic and restorative dentistry by really improving the occlusion beforehand. What else can prejudice our restorative dentistry? the deep overbite. Look at the severity of the overbite in that case. And, you know, kind of misguided dentist when the veneer craze was at its height, put 4 veneers on those front teeth, which lasted a matter of months. And let's not go into the details of the case because they're covered in an article I wrote in The Dentist back in 2014. And what you can see that we actually did pre-orthodontics on these teeth, rapidly and very predictably decreasing the overbite and restoring canine guidance to this case. And this is a very old case now, and these are on these central incisors, four of the first Emax restorations I ever did many, many years ago. And so if we look at the case, we can see that we have room for our post-orthodontic retention. And as you can see, as we take for granted now, highly aesthetic, very strong Emax anterior crowns. What else can prejudice our dentistry? Look at this severe class 3 occlusion, very severe, and also a bruxist. We can see that the posterior teeth, very, very little wear, and again, prior to the restorative treatment, we undertake orthodontics to increase the OVD, open the space for the lateral, and also provide us with a better occlusion. And this is not a material I use very often, usually use it on back teeth, but this was a patient who was very concerned about breaking his restorations. And so this is shell zirconia, this is mill-only zirconia. And what did this allow her to do? Very minimal preparations, but allowed us to use mill zirconia, which is very, very strong and a very, very low fracture rate. Let's not go into this in detail because this is a more controversial area, but certainly during your occlusal examination, look for the posterior interference. What is it likely to be? An over-erupted, a tilted tooth, where there's a missing tooth, things will have moved. And there's plenty of evidence now, and Helen Craddock did a lot of work that was published back in 2007 and 2008. And look at this interesting fact, over half of all types of over-erupted teeth are either a retruded contact and or an excursive interference. But bear in mind that a lot of people cope with these interferences, but the bottom study here, you know, this is quite an old study from 1980 that said, look, small occlusal interferences in certain patients can cause problems and do potentially have the potential to cause TMD. One of the final things I want to consider in terms of disorders is something that isn't covered in the UK that much, and it's the restricted envelope of function. And what is it? Well, it is the mandible coming forwards and upwards during the final throes of the chewing movement. And what you want for that is a sufficient overjet, and you actually want a overbite that is not excessive, so there is room for that to occur. In this case here, you can see the teeth are very vertical with very, very little overjet, and you can see that due to the occlusal plane issues in the mandible, that there is a restriction here on the chewing. So again, I've published on this quite extensively in the International Journal of Advanced Clinical Dentistry and in Private Dentistry a number of years ago. And this is a case that I presented back in Dentistry magazine to just demonstrate this case. And this is a case where there's bone loss around the lower incisors and the patient had TMG symptoms. And look at the excessive wear on the lower incisors and also wear to the upper incisors on the incisal edges. And so this was treated with short-term orthodontics. And really, what did the short-term orthodontics do? Well, you can see bottom right, well, top right, you can see that we have intruded the lowers, increasing the overbite, And we have also provided the patient with an increased overjet, which improves the situation enough that we have decoupled the teeth and allowed that restriction to be corrected. It's interesting to note with this patient, it did provide relief of their TMD symptoms, and in addition to that, it also stabilised the bone loss around the lower incisors. So just to summarise, these are our signs or clues of occlusal disorder. And some of these I wrote up in private dentistry back in 2014, but look for this. Is the tooth loss in excess of the age of the patient? Is the tooth loss interdentine? And is there anterior only tooth loss? All signs of some occlusal disorder potentially. Are there over-erupted or tilted posterior teeth, particularly if there is mobility or bone loss or wear facets? Are there teeth which are particularly out of the occlusal plane, which could be causing a problem? Are there these flat amalgam occlusions where the intercuspal position has been lost and the patient drifts around? Is there any evidence of night parafunction or day clenching, or does the patient have TMD dysfunction or pain within the orofacial muscles? And then finally, I use quite an extensive questionnaire in the practice to find out about this and look at the results of your questionnaire. So I hope that short presentation has been useful for you, looking at the features of the ideal occlusion, but also looking for features of the occlusion where there may be a disorder that you could diagnose. And thank you for your attention.